Today's topic is ischemic heart disease, anesthesia for ischemic heart disease patient coming for non-cardiac surgery. In fact, we have added one more. This thing is about smoking also. So that as all of us know, smoking is very rampant, and that is the cause for the ischemic heart disease. So we'll discuss about smoking also, and that is one of the important topic in the Viva session also, in whatever the case scenario. So we'll discuss about an anesthesia for an ischemic heart disease patient, smoker patient coming for laparoscopic cholecystectomy. And this laparoscopy also, that is one of the other important factor where the ischemic heart disease will be affected by the laparoscopy, because of the increased intra-abdominal pressure, and so many physiologies are there in that. So that is one. I'll try to get the, yeah. So Dr. Afrin, are you there?
Yes, sir. Yes, sir. Good evening.
Yeah. Dr. Afrin is the second year postgraduate in Department of Anesthesia, and she will be presenting about the cases. Okay. Yeah, Dr. Afrin, please continue.
Good evening, everybody. Today my topic is, I'm going to present about anesthesia for ischemic heart disease, who is a patient who is also a smoker, and he's posted for laparoscopic surgery. So 60-year-old male who came with complaints of abdominal pain for 1 week is posted for laparoscopic cholecystectomy under general anesthesia. History of presenting illness. He presented with history of sudden onset colicky abdominal pain over the right hypochondrium, and it radiated to the back and shoulders. There is history of vomiting, but there is no history of fever or jaundice. There is no history of chest pain, palpitations, or any breathing difficulty. Past history. The patient is a known case of hypertension and ischemic heart disease. He had history of anterior wall MI in 2018, for which he was thrombolized, and then subsequently underwent PTCA to LAD. A bare metal stent was placed, and he belongs to NIHA class 2, and functional status is METs more than 4, and currently he is symptom-free. Personal history, he consumes mixed diet with the history of increased fatty foods, and there is no altered sleep pattern or bowel and bladder habits. He smokes about 5 packs of cigarettes in a week for 20 weeks. He has stopped it for the past 5 weeks. Family history, he gives history of hypertension in his father. Treatment history, he is on tablet Telma 5 mg OD, and tablet aspirin 75 mg, and tablet copidogrel 75 mg. He has taken it last 5 years ago. Surgical history, there is no other significant surgical history other than PTCA in 2018. On examination, patient is conscious, oriented, and afebrile. He is moderately built and nourished. He weighs about 80 kgs and his height is 162 kilograms. So the BMI is 29. His pulse rate is 68 per minute, regular in rhythm, normal in volume and character. His BP is 130/70, and it is was taken in the left upper arm in sitting position. In room air, JVP is not raised, and there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. On a systemic examination of the abdomen, on inspection, there is no visible epigastric swelling. The umbilicus is inverted. There are no scars or sinuses. There are no dilated veins. On palpation, the inspectory findings were confirmed. There are no palpable swellings. There is tenderness over the right hypochondrium. Murphy's sign is positive. On auscultation, bowel sounds are present. Cardiovascular system, S1 and S2 are heard. There is no murmur. And respiratory system, bilateral air entry is equal. There are no added sounds. And CNS, there is no focal neurological deficit. Airway, mouth opening is adequate. Thereminal distance more than 6.1, 6.5, and TMJ is more than 1 finger. Teeth are normal. There are no dentures on loose tooth. Malampati score is 2, and neck movements are normal. On investigations, hemoglobin is 13.2, and all other investigations appear to be within normal limits. ECG shows normal sinus rhythm and LVH is present. Echo shows normal left ventricular function and ejection fraction of 63%. Ultrasound findings show distended gallbladder of about 6.4 centimeters into 2.9 centimeters. There appear multiple stones in the gallbladder. The largest is 1.2 centimeters. Murphy sign again is positive. Gallbladder wall thickening is more than 3 millimeters. To summarize, here is a 62-year-old male with abdominal pain, diagnosed to have subacute calculus cholecystitis with hypertension for 6 years, ischemic heart disease, previous MI on treatment for the past 4 years. He belongs to NIH Blue, and clinically there are no cardiac symptoms, and airway and spine is within normal limits. He's posted for lap cholecystectomy.
Sir,
Hello?
yeah, 1 minute.
Okay.
Yeah. Sir, want to start the session, sir?
You start with Jay, no
Yeah,
problem. Please
okay,
start.
sir. So, I think hope you will all seeing the screen. So in this discussion, she has presented the case history, and we'll see these topics like something about how we are going to examine a patient, then something about anatomy of a coronary artery, myocardial oxygen balance, coronary perfusion, then pathophysiology of coronary artery disease, how they manage coronary artery disease, and the risk stratification for cardiac patient coming for non-cardiac surgery. Then something about anticoagulation and something about smoking, as this patient is about a smoker, and the implication of laparoscopy in coronary artery disease patient, and of course the anesthesia for this particular patient. Okay, is it okay, Dr. Afrin?
Yes, sir.
Yeah. So and a few these things. So we'll start with this thing. What what is NYHA classification?
Sir, New York Heart Association classification, it is divided into 4 classes, sir.
Yeah.
Class 1 is there are no symptoms and normal physical activity, no normal functional status. Class 2 is he has mild symptoms with normal physical activity. He's comfortable at rest. There is a slight limitation of functional status. And class 3 is moderate symptoms are present. That is less than normal physical activity. He is comfortable only at rest. There is some limit. No, there is marked limitation of functional status. And there is class 4, in which there are severe symptoms, where even at rest, the patient is not for functional status.
Yeah. Well, you're telling about symptoms. What are the symptoms this New York Heart Association is describing about? What are the symptoms?
So symptoms such as breathlessness, palpitations, and
Yeah.
chest pain.
Yeah. So the symptoms are palpitation, chest pain, and dyspnea. So this is
Yes.
this thing. So any classification which deals only with angina, any classification? So that is a Canadian Society of Classification. So it deals with the same thing about angina. There's class 1,
Okay,
class 2, class 3, and class 4. Same as
Okay.
NYHA. This it says about symptoms. This says about angina. Okay. You're clear?
Okay, sir.
Okay. So
Yes,
what
sir.
angina?
Classical angina is localized to the retrosternal chest pain,
Yeah.
sir.
Okay.
Which
So
leading
angina,
to
what is angina? It is a chest pain because of a
chest
imbalance
pain
between the blood supply and the demand
and
ratio.
the oxygen demand.
Yeah. Okay. So what are different types of angina? Mainly it is stable and
There's
unstable angina.
stable and unstable. Yes.
What is stable angina and what is unstable angina? Which should be of more concern to the anesthetist?
Um,
So stable
One is
angina is a chest pain which occurs to the patient because of the imbalance, whatever the imbalance of coronary artery disease. But this limits less than 5 minutes and usually doesn't occur at rest, and it relieves on medication. Okay.
Yes, sir.
Unstable angina is the other way. Uh, uh, where it doesn't get relieved on rest or with the medication. And this unstable angina is a worrisome for the anesthetist or the physician, where it can lead into myocardial infarction. Okay.
Yes, sir. Yes, sir.
Yeah. So what is ischemia and what is infarction? Next.
Sir, ischemia is decreased blood supply to the tissue, sir.
Yeah, correct.
And whereas infarction is where blood supply is completely stopped.
No. So ischemia is where there is a decrease in the blood supply to a particular area of a myocardium. For example, if it is a myocardial ischemia, and infarction because of sustained ischemia, sustained reduced perfusion, there is biochemical changes which occurs in the tissues, leading to cell death. That is a irreversible changes occurs in the myocardium. That is the infarction. Okay.
Yes, sir.
So, sir, anything more you want to answer about before we go for blood supply?
No, actually, you said about the unstable angina.
Yes, sir.
We'll ask her like how risky it is to have unstable angina patient, and what is the importance, how much importance you should give when compared to stable angina, especially as a non-cardiac anesthetist.
Unstable angina, if it is associated with any ST changes, with any significant ST changes, especially at rest, that that shows that there is an underlying risk. So, anytime if the patient is taken up for the surgery, then there is a higher chance of intraoperative MI.
Yes.
And
when you have unstable angina, as anesthesiologists, will not have any time period to tackle the situation. If it is a stable angina, you will have time to think and manage accordingly with the help of a cardiologist in the interventional, maybe with interventional technique. So this is very important, and this because this difference makes a lot of anesthesia management in the theater. Okay. Okay, Vijay. So this is very important for this thing of your postgraduates. You can go to the coronary anatomy.
Yes, sir. So, what is the blood supply of the heart? Or how do you
so the blood supply is mainly by the right coronary artery and the left coronary artery.
Yeah.
The left coronary artery supplies the right side of the ventricle, right atrium. It
Wait. Be clear. Repeat it again.
It supplies the right ventricle and the right coronary artery.
Yeah. Correct.
It arises from the coronary sinus, right side of the coronary sinus, and supplies the right ventricle, right atrium, and also a part of the left atrium and left ventricle, a small part of the diaphragmatic part of the left ventricle, and it also supplies the posterior inferior part of the IV septum.
Okay.
And the left coronary then it travels to, it gives the right ventricular branch and the atrial branches. The atrial branch supplies the SA node, and the right ventricular branch gives the right conus artery and marginal arteries. When and it passes through the IV groove, the right cardiac border, and gives the posterior descending artery. And 70% of the times, the right coronary artery gives the posterior descending artery. So that is called as right dominant. And then there is the left coronary artery, which supplies the left ventricle, and most of the left atrium, and anterior part of the right ventricle, and anterior part of the ventricular septum also. Then that continues into the atrioventricular groove and gives the left anterior descending, and the circumflex artery, which in turn gives the obtuse marginal.
Yeah.
Then that obtuse, after giving the obtuse marginal, continues to give the in some patients, I mean, 30% of the population, it gives rise to the posterior descending artery. And this time, this is called left dominant.
Okay. So it's right and the left coronary artery. So what are the main branches of the right coronary artery? You are telling about one branch, posterior descending. What is the other branch?
Yes, sir. The right ventricular atrial branch and the marginal artery and the posterior descending artery, sir.
Posterior descending artery, and then posterior left ventricular artery.
Left ventricular.
Yeah. So these are the two branches of the right coronary artery. Okay. So coming to left coronary artery, there is a name for other name which is called as widower artery. Why is it? You know about it?
No,
Left
sir.
coronary artery is otherwise called as widower artery because that is the main supply which supplies the left ventricle and supplies majority of the area. And any obstruction, critical obstruction or total occlusion, the patient may go in for sudden cardiac death. Okay. So it is called as widower artery because of that there are a lot of death and of patients. So it is called as widower artery. Okay. So what are the branches of left anterior descending artery?
Left anterior, it gives the
left
right
main gives into two branches: left anterior descending and the
circumflex.
Okay. So what are the branches of left anterior descending?
It gives rise to the right and left diagonal arteries, and then the septal branch, which supplies the interventricular septum. The right and left diagonal arteries. The left one supplies the anterior surface with more in number. The right one is the smaller or the rarer branches.
Yeah.
Diagonal.
Okay. So septal and the diagonal artery are the main branches of the left anterior descending artery. So, so you are told about the dominant coronary artery. So wherever, whichever right or the left, where PD arises, it is called right dominant or the left dominant. Okay. So what is the peculiarity of the coronary blood supply to the myocardium?
It receives the blood supply. It receives blood supply only during diastole.
Diastole. Good. Okay. So why not in systole?
So because when the heart contracts, the intermyocardial arteries, they get compressed, hence the blood supply is stopped. So when the diastole happens, the arteries dilate and blood supply is there.
Yeah. So that is called throttling effect.
Throttling,
okay.
Yes.
Yeah, throttling effect. Because of the muscles in the left ventricle, muscular mass, this coronary arteries get compressed during systole. So there is very minimal blood supply during systole. That is during the isovolumetric contraction phase.
Yes.
Okay. So main supply of the myocardium occurs during the isovolumetric relaxation phase. Okay.
Yes.
You understand? But
yes.
In contrary, right ventricle gets supplies during both systole and diastole because
yes,
of less myocardial muscle in the right ventricle. Okay, you understand? So left
Yes, sir.
ventricle gets blood supply mostly during diastole, and right ventricle gets supply on both systole and diastole. Okay.
Yes, yes, sir. Okay, sir.
And one more, this thing is all the coronary arteries are end arteries.
Yes, sir.
Okay. So coming to next, what is coronary steel?
Coronary steal syndrome is related to the subclavian.
Coronary steel. So when there is a phenomenon of vasodilatation of the blood supply, when the vasodilatation, the blood supply is diverted from the ischemic region to the non-ischemic region. Okay, the non-ischemic region steals the blood from the ischemic region. That is called coronary steal phenomenon. Okay.
Okay, sir.
Okay. So next, what is the coronary perfusion pressure?
The coronary perfusion pressure is the difference between the arterial pressure and the ventricular pressure.
No, it should be very specific in that. Coronary perfusion.
The aortic
arterial diastolic pressure minus left ventricular end diastolic
pressure.
Yeah, that should be very particular, because all this coronary artery blood supply and imbalance depends upon the coronary perfusion. Okay,
Yes.
so this coronary perfusion, you should be very clear. What is it? So what is the coronary perfusion pressure? It is a
arterial diastolic pressure minus the left ventricular
end diastolic pressure. Okay. So we will be talking about anesthesia management or the rhythm management and so on, particularly to the heart rate. Okay. What is the relationship of tachycardia to coronary perfusion?
If there is increase in heart rate, the coronary perfusion will decrease.
Why? That is correct, but why?
Because there is less supply to the heart as such. The diastole
No. In the tachycardia, the diastolic time decreases.
Yes, sir.
Okay, but the coronary blood flow occurs mainly during the diastole. You understand that? Okay.
Okay, sir.
You understand? So in tachycardia, there is a decrease in the diastolic time. Because of that, there is a decrease in the perfusion to the myocardium.
Okay, sir.
Okay, that is the importance of tachycardia. That is why we are very concerned about tachycardia during anesthesia, intraoperative period, or during induction and extubation. Okay.
Okay, sir.
So what are the main causes of myocardial imbalance? Causes of myocardial
because of the ratio of oxygen supply and oxygen demand are there is an imbalance between that.
Either there is decreased oxygen supply or increased demand. That is the myocardial oxygen imbalance. So what are the reasons where there is decreased oxygen supply?
Decreased oxygen supply is seen in increase in heart rate.
So no, you should be very when you explain to the examiner, you should be very clear in that. Okay, so myocardial imbalance occurs when there is a decrease in the supply or increase in demand. Okay.
Yes.
So what are the conditions which there is a decrease in supply? So decrease in supply may be because of decrease in the coronary blood flow or the decrease in the content of the oxygen.
Yes.
Okay. So in that, what are the conditions which causes decrease in the coronary blood flow? What you told is tachycardia.
Yes, sir.
Then coronary artery disease. Yeah. Then.
And if the coronary vessel diameter is decreased.
Yeah.
That's the coronary artery disease.
Yeah.
And the oxygen content is low if in cases of anemia.
Decrease in coronary blood flow occurs when there is a coronary artery disease or tachycardia, or there is an hypotension, when there is a increase in preload of a patient, or sometimes when coronary vasospasm occurs due to hypocapnia. So these are the reasons where there is a decreased coronary blood flow to the myocardium.
Okay.
Next is the decrease in oxygen content of the blood. Where it occurs?
In case of anemia,
Good, anemia.
the oxygen is supply is less, or
Yeah.
in methemoglobinemia.
Yeah. So hemoglobinemia occurs where there is a reduced release of oxygen. That is the oxygen dissociation curve shifting to the left. ODC shift to left. So anemia, ODC, whatever the factors which shift the ODC to left, and hypoxia. That is a low FiO2.
Yes.
Okay.
Okay.
So this finishes the decrease in oxygen supply. So what are the factors which increases the oxygen demand?
If there is increased contractility, if the BMI is
increased myocardial contractility, tachycardia, when there is an increase in the afterload where heart has to pump against the increased pressure, or there is an increase in preload, or where the generalized there is a hypermetabolism in patients.
Yes, okay, sir.
Okay, so these are the conditions where there is an increase in the oxygen demand.
Okay, sir.
Okay, so this whether there should be one end there should be decrease in oxygen supply, other end there should be increase in oxygen demand. These causes the imbalance in the oxygen balance. Okay,
sir.
so in anesthesia, where this patient is a coronary artery disease patient, where as such there will be a decrease in the coronary blood flow, isn't it?
Yes, yes, sir.
Okay, so in this patient, if we cause tachycardia, it will affect the
precipitate
ischemia and infarction. Or if you cause hypotension, it will again cause the ischemia or infarction.
Yes.
We should be very careful about rhythm and the blood pressure. Of course, about the blood loss. Blood loss is not under our control. That is in the control of the surgeon. But we should be very careful in monitoring the blood loss.
Yes, sir.
Okay, so suppose in cholecystectomy, some hepatic vessel gets injured and there is a sudden loss. Already this patient is a coronary artery disease patient. There will be definitely an imbalance between the supply and demand.
Yes, sir.
Okay.
Yes,
understand? So now coming to what are the risk factors for the patient to develop coronary artery disease? So it is divided into modifiable and unmodifiable
yes,
risk factors. So what are the modifiable risk factors and what are the unmodifiable risk factors?
The most common modifiable risk factor is hypertension.
Okay.
And the second most common is hyperlipidemia. Then diabetes, obesity, smoking, leading a sedentary lifestyle, and poor diet.
Okay.
Are all modifiable risk factors.
Okay.
And non-modifiable risk factors are age. And if the person is more than 35 years of age, and gender is males are more prone to for coronary artery disease. And if the patient has had a family history of coronary artery disease, that is also most likely it's non-modifiable, and ethnicity also. Yeah.
So coming to this gender, you're telling male are more affected than the female. But there is a recent study which says the post-menopausal women are increased risk of coronary artery disease in compared to the males.
Okay, sir.
Okay.
Okay, sir.
Yeah. So now, what is rate pressure product and what is its significance in anesthesia? What is rate pressure product? That is RPP. So rate pressure product is the multiplication of heart rate to systolic blood pressure.
Okay, sir.
Okay. So if this rate pressure product is more than 20,000, then the particular patient is in high risk of developing perioperative myocardial infarction. So
Okay.
it is not only the rate pressure product, there are other indices which predicts the perioperative MI. One is rate pressure product, other is triple index. The triple
Okay, sir.
index is heart rate into systolic blood pressure into pulmonary capillary wedge pressure. That is triple. Okay, rate
Okay,
pressure
sir.
depends upon two factors, heart rate and systolic blood pressure.
Okay,
Triple,
sir.
it includes pulmonary capillary wedge
Pulmonary
pressure
capillary.
also. Okay.
Okay, sir. Okay,
And
sir.
what is the use of cardiac risk stratification for non-cardiac? There are a lot of indices which predicts the which helps in risk stratification for non-cardiac surgery. What is
Yes.
the use of it? Why we should do it?
So to determine how much the person is at risk for developing an MI intra-op or in the peri-op period, so during intra-op or post-op period.
Yeah.
We can get an idea according to the type of surgery and the patient's condition.
It helps the healthcare, that is the anesthetist, to weigh the benefit and the risk of the surgery. That is one.
Yes, sir.
Second is it helps to evaluate the presence and the severity of the cardiac disease.
Yes.
Okay. And third, whether there is a need for preoperative intervention before the surgery for the existing cardiac disease. For example, patient might need for stenting or bypass surgery before this procedure. So this risk stratification helps to determine whether the patient has to undergo some other procedure before this cholecystectomy. Okay. Fourth, it identifies the perioperative risk factors. For example, anesthesia of suppose if the patient has already has some other problem, and this has to be identified. For example, patient with thyroid disease or which itself has so many factors which will affect the coronary artery patients. So this stratification will try to help to identify the perioperative risk factors. And fifth, it tries to modify the risk factors. And sixth, mainly, it optimizes when we can accept for the patient for surgery. So these are the uses of the risk stratification of a cardiac patient for non-cardiac surgery.
Okay, sir.
Okay, so this are the uses of that. Okay, coming to what is the metabolic equivalent or METs?
Sir, it's the functional. Yeah, it is calculated by the Duke's activity status index, sir.
Okay.
And so one, it represents the oxygen consumption. So one MET is about 3.5 ml per kg per minute oxygen consumption, sir.
So when do you say which how many METs patient is fit or he has reduced morbidity or mortality during the surgery?
Should be more than 4, sir.
Yeah, 4 to 6 or more than 6 is ideal. Yeah. Okay. So how do you optimize this patient preoperatively?
So preoperatively, we should make sure that the patient has. The first thing is about the investigations. First thing is symptoms, to see if the patient has any symptoms and to evaluate if there is any need for emergency cardiac surgery. And if there is, then we have to evaluate the patient's condition, if there are any symptoms, if the investigations are all normal, and if it is a low risk with the surgery. And
so
if not,
this particular patient has is asymptomatic, isn't it? But he has a stent in the right coronary, or what you told?
left anterior descending.
Left anterior descending.
Left coronary.
Okay.
Yes, sir.
Yeah. Okay. So as such, this patient is asymptomatic, isn't it?
Yes,
okay.
Sir. Yes, sir.
Okay. So, what is the goal of the medical management for this patient?
The goal is to maintain a heart rate of
good.
about less than 60 to about 60 to 70, sir.
Yeah. Okay.
And tachycardia is avoided
Okay.
pre-op also.
So it is not only the heart rate, it is
Because
about the blood pressure also.
blood pressure.
Yeah. So this patient is an hypertensive, isn't it? So we have
Yes,
to
sir.
optimize the heart rate and the blood pressure for this patient. So what are the drugs you want to continue on the day of surgery?
So beta blockers should be continued on the day of surgery, sir.
Okay.
If the patient is taking beta blockers, that should be continued.
Okay.
And what should be avoided?
So coming to what are the drugs you should
aspirin.
want to stop before surgery?
The drugs that should be stopped are the patient is taking clopidogrel, so that should be stopped about 1 week before the surgery, sir. And aspirin, it depends on the type of surgery and about the the patient's condition. For example, if the patient has a coronary stent, then he should remain on low dose aspirin through surgery, unless the surgical
come to
risk.
that later. So one is the all this clopidogrel, whatever it is, antiplatelets has to be stopped before surgery. Okay.
Yes, sir.
So what is the mandatory duration of dual antiplatelet therapy for a bare metal stent? Your patient has a bare metal stent or a drug-eluting stent?
The patient has a bare metal stent.
Bare metal stent. So what is the mandatory duration for a dual? What do you mean by dual antiplatelet therapy?
Sir?
What do you mean by dual antiplatelet therapy?
The clopidogrel, he should be taking clopidogrel and
aspirin. Okay. So what is the minimum mandatory period for a dual antiplatelet therapy if the patient has a bare metal stent? Minimum, you should patient has to continue for 4 to 6 weeks. 4 to 6 weeks. And then single antiplatelet, maybe aspirin, has to be continued
for
lifelong. Yeah, lifelong. Okay. So coming to when a patient with the bare metal stent can, when a patient who has a bare metal stent can be taken up for elective surgery.
If it is after 30 to 45 days, then he can be taken up for the surgery under aspirin cover.
Yeah.
And if
so
it is
6 weeks,
it is less.
Elective surgeries can be taken up after 6 weeks if a patient has a bare metal stent. Okay. So coming to the other drug-eluting, what is the minimum duration of a dual antiplatelet therapy for a drug-eluting stents? How long you should have dual antiplatelet therapy? Because all these things are important when you accept a patient for elective surgery. Okay. Suppose if a patient comes with a bare metal stent, you should not accept for elective surgery before 6 weeks of bare metal stent implantation. Because 6 weeks is a mandatory period for dual antiplatelet. Okay. Emergency surgery is totally different. I'm talking about elective surgery. So this patient of drug-eluting stents needs 12 months of
more than
12
1
months.
year.
12 months. Okay.
1 year.
Mandatory duration is 12 months for a dual antiplatelet therapy. After that, aspirin has to be continued.
Should be taken. Yes.
Yeah. Then when yes, sir.
Vijay, two questions are just information.
Yeah.
First one is, Afrin, you said about the coronary perfusion pressure, diastolic pressure minus left ventricular end diastolic pressure. You have any? You will be able to measure that left ventricular end diastolic pressure. Is there any possibility? Is there any way to measure that? by anesthesiologist.
Mm,
Diastolic pressure, of course, you check with your regular BP
mm,
apparatus. And left ventricular end diastolic pressure is important to know whether coronary perfusion is maintaining. So, is there
mm.
any way? Okay, I give you a clue. Is there any cardiac anesthesia person who do that regularly? Have your cardiac anesthesia posting completed
No, sir.
or not?
Not
Okay,
yet.
normally we do with the
No, sir.
pulmonary artery catheter. So we put a pulmonary
Okay.
artery catheter and we do pulmonary artery wedge pressure. Normally, pulmonary artery wedge pressure is equal to left ventricular end diastolic pressure if there is no valvular pathology. So this can be
Okay,
measured
sir.
in the help of pulmonary artery catheter, and it is done in cardiac theater as well as all pre-cardiac transplant patients. Okay, this is one
Okay, sir.
information. And second thing, the medications to be continued in the preoperative period. As per the classification, all cardiac medications, not only beta blocker, all antihypertensives also has to be continued. If you stop antihypertensive on the day of
Okay, sir.
surgery, suddenly there will be reflex hypertension. So even that is
Yes.
very
Okay,
detrimental
sir.
to the cardiac system. So all antihypertensive,
Mm.
all cardiac medications, now variety of medications they are writing. Every patient is on either 2 or 3 cardiac
AC
medicines.
inhibitors, sir.
If the patient is only on AC inhibitor and beta blocker, if you can switch over to any other antihypertensive, if you have time to switch over, it is fine. Otherwise, we can continue AC inhibitor in this
Okay,
current
sir.
concepts. The idea is to have a good control over the BP and heart rate in the pre-op, intra-op, and post-operative period. So suddenly, if you stop any of these medications, as already Dr. Vijay said, they are coronary perfusion pressure, rate pressure product, triple index, everything will increase. And as per the auction supply demand ratio,
Okay.
this demand is increased. And naturally, the supply also comes down
Okay,
with
sir.
the tachycardia. Okay. Okay. Fine. You please go ahead. These are the 2 points I would like to add.
Okay, sir.
Okay. So coming back to this, when a patient is having a drug-eluting stent, when the patient can be taken up for elective surgery?
After 1 year, sir.
Yeah, 12 months, because that is the minimum mandatory period of dual antiplatelet therapy. Okay.
Yes,
So
sir.
what do you mean by bridging therapy?
Bridging therapy is for the drugs which have to be stopped, but for example, warfarin, if the patient has been on warfarin, that is supposed to be stopped. So there should be some
some other drugs.
Some other drug, so which can be
like
continued.
Glucoprotein,
Like
2B3A inhibitors we can use. Okay.
And for clopidogrel also, you can,
yeah. Okay.
glycoprine, those can be
okay.
started also.
Okay.
For patients who have not completed the dual antiplatelet therapy.
Okay. So for clopidogrel, we can use GP
2B3
inhibitors. Yeah.
Yes. Sir.
Okay. Can heparin be used to bridge antiplatelet therapy?
Yes.
Heparin cannot be used as to bridge antiplatelet because heparin does not have antiplatelet efficacy.
Yeah.
Okay.
Okay, sir.
Yeah. So, and coming to neuroaxial blockade. When a neuroaxial blockade is planned, when to stop clopidogrel? How long clopidogrel has to be stopped?
7 days before surgery.
Yeah, 7 days before surgery has to be stopped if you plan a neuroaxial blockade. For what about aspirin?
If aspirin alone the patient is taking, then it's not a contraindication.
For a neuroaxial blockade. Okay. So when to stop GP2 2B3A inhibitor? So it has to be stopped for 48 hours. Okay, that is why it is a bridging therapy. Okay, if it is for more than clopidogrel, then there is no use of having it as a bridging therapy. So it has to be stopped for 48 hours before the molecular, neuroaxial blockade. So when to stop low molecular weight heparin?
Low molecular weight should be stopped 12 hours prior.
So there is 2 doses of low molecular weight heparin, therapeutic and
The last, hello.
when the therapeutic dose of low molecular weight heparin is given, it has to be stopped 48 hours. When it is a prophylactic, it has to be stopped for 12 hours.
Okay, sir.
Okay, before a neuraxial blockade.
Okay,
Okay.
sir.
When to restart anticoagulant after surgery? So we are talking till now. We are talking about how to stop or when to stop anticoagulant or antiplatelet. When to restart after surgery? Suppose if cholecystectomy is over, when to restart it?
Which of the drugs, sir?
Any anticoagulant or any antiplatelet. So when bleeding.
If there is
When
no
there
risk
is no
of,
bleeding or when you don't expect a bleeding to occur after that, and complete hemostasis can be started after 24 hours.
Okay, sir.
Okay. So when do you remove epidural catheter after anticoagulant?
About 48 hours, sir.
So it depends upon what anticoagulant you are using. Maybe a conventional heparin or a low molecular weight heparin.
Okay, sir.
Yeah. Then, sir, anything more, sir, before we come to smoking part?
Suppose the patient is on regular heparin, would you continue till the day of surgery or you will stop before that? The previous day night? If you are planning only GA, of course, lab chole, you are planning for general anesthesia. When will you stop heparin? So many patients are on regular heparin nowadays.
6 hours before surgery should be stopped, sir.
Previous day night you can give, morning dose you can avoid, and you can go ahead for GA. That is right. And as Vijay said, that depending upon the stent, but any stent now it is very high risk. We should continue at least 6 hours prior to surgery. And the restarting is directly depends upon the intraoperative and postoperative bleeding. Intraoperatively, if it is very oozy, you have to be very careful. And in the postoperative period, if your drainage is very minimum for a minimum of 3 to 4 hours, then with the consultation with surgeon, we can restart. That is fine. Okay, Vijay. Okay, we can go ahead.
Yes, sir. So coming to the smoking part, what are the gaseous and the particulate components of smoking?
There is nicotine, there is carbon monoxide, and there is hydrogen cyanide.
Yeah, so carbon monoxide is a gaseous component.
Gaseous.
Nicotine and tar are the particulate component of smoking. Okay.
Yes, sir.
So what is the addictive component? Which there are so many gaseous and particulate component in smoking.
Nicotine, sir.
Yeah, nicotine is the addictive component of a smoker. Okay. What is the normal carboxyhemoglobin level in a human being?
Should be less than 1.5.
Yeah, good. 1.5%. Okay. So what is the level in smokers?
That is about 2 to 12%.
Yeah, it's more than whatever.
More than.
Yeah, more than 2.
More than 2.
Okay. So coming back. So what is the effect of carbon monoxide on oxygen?
Carbon monoxide has greater affinity to hemoglobin than oxygen.
Good.
So it shifts the oxygen hemoglobin dissociation curve to the left side, which means there is less unloading.
Yeah.
And the 2,3-DPG also it decreases.
No, so, will carbon monoxide affect 2,3-DPG? Yeah. So what is the effect of P50? Carbon monoxide on P50?
It increases the.
No, it reduces the P50. Yeah, it reduces the P50. Okay. So in other words, what are the causes of hypoxemia in smokers? So there is increased oxygen affinity. And ODC is to left and there is a reduction in P50. So these are
The
the
oxygen from the myocardium.
yeah. So these are the causes for hypoxemia in smokers. Okay.
Okay, sir.
So we talked about carbon monoxide. We'll
Mm.
talk about nicotine. What are the effects of nicotine in a smoker patient?
It causes increase in blood pressure and heart rate, and
Okay.
causes vasoconstriction. So, and the myocardial oxygen demand is increased.
Yeah. So the
Mm.
nicotine stimulates the nicotinic acetylcholine receptors in the brain. Okay. So it
Yes.
stimulates and secretes neurotransmitters. That is why this addiction acts are happening. Okay. So this nicotine stimulates the nicotinic acetylcholine receptors in the brain, and it stimulates neurotransmitters such as noradrenaline, adrenaline, vasopressin, serotonin, dopamine, beta endorphin. So that is why we have an high beta endorphin. It creates a high. That is the addictive part. Okay. So nicotine also increases cardiac output, and it causes a risk of dysarrhythmias. So patient sometimes will have ectopics and arrhythmias because of increased nicotine content. Okay.
Okay, sir.
Okay. So coming to next, what do you mean by pack years of smoking?
Pack years is the number of packets smoked per day into the number of years the person has.
So it does not mean pack. Pack means it is 20 cigarettes per day. Okay, it is not 10 or this thing. 20 cigarettes per day for 1 year is called one pack year. Okay.
Yes,
so what is the cardiovascular effects of smoking? We'll come to system wise. Cardiovascular effects of smoking.
Yeah. In cardiovascular, it stimulates the adrenal medulla, and the adrenaline is produced, which causes increased contractility and increase in oxygen demand.
Yeah.
Also stimulates the sympathetic system. So there is increase in heart rate, BP, and peripheral vascular resistance.
Okay.
Also, it resets the aortic and carotid body receptors.
Okay.
So there is increase in BP, and there is no feedback mechanism.
As such, this smoking as such increases the incidence of coronary arteries 3 to 5 times. There is an increase in the incidence of coronary artery disease. Okay. And this reduced oxyhemoglobin, it causes imbalance between the myocardial oxygen supply and demand ratio.
Yes, sir.
And smoking causes endothelial injury, and because of it, it promotes atherosclerosis.
Yes, sir.
And as such, what you're told, because of this adrenaline, noradrenaline, and so on, it increases the peripheral vascular resistance, and sometimes it promotes thromboembolic events and stroke.
Yes, sir.
Okay. So coming to what are the respiratory system effects of smoking?
It decreases the FRC, decreases the compliance, causes central respiratory depression, and it also causes increased shunt, VQ mismatches present, and ciliary motion is decreased.
Yeah, decreased.
Surfactant is also decreased, surfactant levels.
Okay.
And,
so the smoking, it increases almost 90%. There is an increase of lung cancers. It causes 90% of lung cancers are due to smoking. Okay.
Yes.
And 20% of smokers are COPD patients. It increases the incidence of COPD. Okay.
Yes,
and it causes smaller airway obstruction due to increase in the secretions. And there is a fall in FeV1. It causes emphysematous changes and bullous changes in the lung. Okay.
Yes,
and it increases the closing volume. Because it increases the closing volume, the smaller airway gets closed.
Closed, yes, sir.
That is why the patient, that is one of the reason the patient will have hypoxemia.
Okay, sir.
Okay. And it increases the cough reflex.
Yes,
Okay.
sir.
And smoking causes bronchospasm and laryngospasm.
Yes, sir.
Okay. And it also increases, as I told you, it increases the mucus production and increases the viscosity also. Because of that, the smaller airway gets obstructed and closed.
Yes, sir.
Okay, so these are some of the respiratory effects of smoking. What are the other system smoking effects?
Nicotine crosses the blood-brain barrier.
Okay,
So, through central nervous system.
okay. Let me tell. So it relaxes the lower esophageal sphincter. So what does it mean to the anesthetist?
There is an increase. Any patient will be appearing as full stomach.
Yeah. So it increases the
Chances of
chances of
aspiration.
aspiration, regurgitation, and aspiration. Okay. Smoking
Yes.
increases the acid secretion in the stomach. So one
Yes.
side it relaxes the sphincter, other side it increases the acid secretion and the gastric volume. Okay, so that means that there is an increased chances of aspiration
Aspiration.
during
Yes, sir.
induction. Okay, and smoking
sir.
causes increased post-operative nausea and vomiting. So these are some of the other system effects of smoking.
Okay, sir.
So coming to intraoperative period, what are the complications you will expect in a smoker patient during intraoperative period?
There is aspiration, sir.
Yeah,
There's hypoxemia.
Ah.
Then hypoventilation can occur, bronchospasm,
Bronchospasm, laryngospasm, good.
chances for reintubation are high.
Yeah. So patient may end up with bronchospasm, laryngospasm, aspiration, hypoventilation, hypoxemia, and pulmonary edema. Okay. So these are some of the intraoperative complications. What are the postoperative complications?
Post-operatively, the patient is more prone for an MI, for cardiac arrest,
Good.
and the reintubation in the post-op period,
Yeah,
and continued continued mechanical ventilation.
Yeah.
Patient is also prone for pneumonias.
Yeah.
Increased susceptibility to infections.
Yeah, good.
And
good. Wound infection, infection rate is increased.
Getting to septic
Intubation
shock.
rate. Smoking causes increase in the ICU and hospital stay.
Yes, sir.
Yeah. Okay. Yes, sir.
Vijay,
Yes, sir.
I'm not interfering in every question, but cumulatively I'll
yes, sir. Yes, sir.
I'll inform 3 points.
Yeah.
One is the difference between regular heparin and low molecular weight, which is much safer for anesthetist or for the surgeon? Heparin?
Sir, low molecular weight, sir.
The idea is of asking this question is regular heparin we can reverse with protamine.
Yes, sir.
But low molecular weight we cannot reverse. So this is much safer for a surgeon and anesthetist for any pre-op or intraoperative period. Okay. Second thing, you said about carboxy hemoglobin.
Yes.
Okay. This is in smoking patients. Okay.
Yes, sir.
Patient is not a smoker, but this patient comes for anesthesia. This patient will have a more value of carboxyhemoglobin. Can you give me one example for such patient coming to operating room on emergency basis or sometimes elective, but mostly on emergency basis?
With increased carboxyhemoglobin.
Carbon monoxide, carboxyhemoglobin, all these values will be, especially carboxyhemoglobin, especially in burns. If the patient is suffering from burns in a closed compartment or the locked house or in locked chamber, if they come for emergency surgery, maybe collagen application or whatever it may be, but their saturation level will be very less. So we should treat like a smoking patient. Okay. Third important point is all the smoker patients, whether they are very high risk during intubation or extubation.
During extubation, sir.
Why?
Because after extubation, there is the secretion, there is decreased mucociliary activity, so the secretions will not be cleared by the one patient. So there is chances of re-intubation.
Okay, fine. That is, that may be after few hours. Immediately after extubation, all these patients are prone for laryngospasm. Okay. So what was taught to us when we are PGs were, whenever the patient is a non-smoker and not stopped for more than 4 weeks, always extubate in a deeper plane of anesthesia. Okay. Keep
Yes.
them
Okay.
in nice, good sedated way. Just if the respiratory efforts are very good, and no need to be fully alert or struggling for extubation, not like usual time. Keep them in the deep plane and extubate. So this laryngospasm chance will be very less. Okay, you put all the you extubate now on table. You are alone. Nobody else is there, and if the patient goes for laryngospasm, the saturation started falling. Immediately, what will you do?
Mask, sir.
Yeah, good. So my experience is I never reintubated in 90% of the cases. I keep full 100% oxygen, ventilate the patient. Don't allow them for spontaneous breathing. 100% oxygen with steroid cover almost recovers 90% of the patient. Okay,
Okay, sir.
fine. Thank you. Please go ahead, ma'am.
Thank you, sir.
Yes, sir. So I think we have completed about smoking. What is the clinical effects of cessation of smoking? That is the last this thing.
It depends on the duration of how long he has stopped smoking, sir.
Yeah.
If it is within 12 hours, then it decreases the sympathetic effect of nicotine,
Okay.
and the P50 increases, and the plasma level of carboxyhemoglobin decreases. If it is a few weeks to months, then there is decrease in mucus production, sputum production, and then there is improved mucociliary action. So the swallowing function increases. So there is decreased cough or wheezing, those complications. And if he has stopped for more than 6 weeks, then normal immune function may return, and the hepatic enzyme activity which it blunts, those also become normal, and my alveolar macrophages also tend to decrease.
Yeah. Okay.
So the optimal time should be about 4 to 8 weeks for the patient to stop smoking.
Okay. So coming to laparoscopy as such, what are the side effects of hypercapnia due to carbon dioxide insufflation in this patient?
Yes, so there is the carbon dioxide can extravasate into the tissues. That can cause subcutaneous emphysema,
Okay.
pneumomediastinum, and pneumothorax.
Okay.
And this can cause, this may lead to continued mechanical ventilation into post-op period. It can also cause venous carbon dioxide, venous embolism it can cause. And this happens if there is unintentional insufflation into any open vein.
No. Question is not about this thing, hypercapnia. Carbon dioxide is insufflated and patient will develop hypercapnia, isn't it? It is not about tissue perforation or vascular perforation. Carbon dioxide is insufflated, it gets absorbed, and patient will develop hypercapnia. That is the physiology of laparoscopy with carbon dioxide. So because of this hypercapnia, what are the things will happen in patients which will affect this coronary artery disease patient?
There'll be sympathetic stimulations.
Yeah.
Which
Okay.
will cause.
So it will cause increase in heart rate,
BP, arrhythmias.
volume, increase in myocardial contractility. Myocardium is very susceptible for catecholamines. So that is dysarrhythmias. Okay. And this can cause increase in the pulmonary vascular resistance. All this will affect the any patients, particularly coronary artery disease patient.
Yes.
And all this will increase the incidence of perioperative ischemia and infarction.
Yes, sir.
Okay. So because of this, can laparoscopy be done without a gas insufflation?
Earlier on, there were other methods of inflation,
Yeah.
but now only carbon dioxide is preferred.
No, not about others insufflation. I'm
Mm.
talking about gas insufflation, carbon dioxide, air or helium, whatever it is. Everything is going to cause problem. Okay, now there is other this thing. The peritoneal cavity can be expanded using a abdominal lift with a fan retractor. Okay,
sir.
so this is one other technique where laparoscopic can be done without gas insufflation, because it avoids the hemodynamic response, increase in intra-abdominal pressure, increase in intrathoracic pressure, and associated complications.
Okay, sir.
Okay, so it is a fan-like abdominal wall lift. Okay,
Okay, sir.
what are the complications you can expect in this patient due to laparoscopy? For a patient of coronary artery disease.
Coronary artery disease.
Yeah. Patient
So
can have
because of
hypotension because of
hypotension, because of
because of
vagal stimulation will be there.
Increase in, not because of vagal,
And
vagal stimulation.
Decrease
Because
in venous return.
venous return because of
increased abdominal pressure.
intra-abdominal pressure and intrathoracic pressure.
Correct.
There is
Yes,
a
sir.
decrease in the venous return, and it can cause hypotension. Okay, there will
Yes,
be a raised intrathoracic pressure. The same thing has happened, and because of hypercapnia, it can cause tachycardia, increase in stroke volume, or increase in the myocardial contractility. All can affect the patient with coronary artery disease.
Yes, sir.
Okay, and hypercapnia can predispose this myocardium to catecholamine and can cause arrhythmias.
Yes, sir.
And as such, hypercarbia can cause acidosis and related hemodynamic changes.
Yes, sir.
Okay. So what complication you can expect after laparoscopy in postoperative period? Patient usual complication is nausea and vomiting.
Yes, sir.
So this nausea and vomiting, stretching, and stress can cause increase the patient risk for ischemia and infarction.
Okay, sir.
Okay, sir. Anything else you want to ask about laparoscopy for this this thing, sir? Any questions?
Almost you covered. Only thing we should the goal for all the postgraduates is please avoid tachycardia. Give very good deeper plane of, maintain the deeper plane of anesthesia. And
okay,
the thing is, whenever there is tachycardia, please don't use beta blocker. Always what I do is identify the reason for the tachycardia. Whether the patient is coming out of muscle relaxation, or whether the patient, the pain relief is not adequate, or they're stretching some of these intestines where the relaxation is again not adequate. Please find out the reason for tachycardia, maybe temperature, or already as Vijay says, acidosis. Please take ABG, make sure that PO2, PCO2 is normal. Find out all the reasons, root cause, before treating only with beta blocker. So please avoid tachycardia throughout the surgery. And finally, my small doubt is, if at all there is any ST changes in the intraoperative period, immediately what will you do? Tell me. Suddenly there is ST changes. This is a post-PTCA patient. Laparoscopic surgery is going on. Suddenly there is an ST elevation or ST depression. What will you do?
I'm not.
Okay. If you are using a nitrous, keep 100% oxygen. Okay. Use some more morphine. If you are already using morphine, use morphine. Otherwise, please add a dose of morphine. Then next thing is, please try to add nitrates, sublingual nitrates. Make the position normal. Ask them to stop the surgery. And if the surgery is at the end of, there is no major bleeding. If this life, it's a detrimental to life, no other choice, because we have to give heparin. And already the stent is inside. It could be a stent stenosis. Yeah, but you don't have time to go to cath lab and do one more plasty or anything. So immediately, as anesthesiologist, we should do all these measures in the operating room or the immediate post-op. Vijay would like to
Okay,
add
sir.
anything for this intraoperative ST changes?
Yes, sir. We'll come. I think I will start one by one. I thought.
Okay, okay. Sorry,
Yeah.
I think
Yes,
I
no
was in a
problem. No.
target. Okay,
So,
okay.
what are the perioperative complications before planning your anesthesia? So, you should expect some of the complications so that you can deal with it. Okay, as Sir was telling, one of that. So, what are the complications you would expect in this patient during preoperative, intraoperative, or postoperative period?
So preoperatively, the patient will have, because of the surgery itself, the patient can have anxiety, which can cause sympathetic stimulation and cause
So, whatever it is,
increase
the patient ultimately will have either ischemia or infarction or
inf-
arrhythmias. So only
yes,
these
sir.
three things will complicate a coronary artery disease patient. Okay, so whether it is anxiety or whether it is sympathetic stimulation or your stress response, whatever it is, ultimately your worry is about ischemia, infarction, and arrhythmias,
Yes,
isn't it?
sir.
So these are
Yes, sir.
the three major complications you would expect in this patient in the perioperative period.
Yes,
Okay.
sir.
So how do you investigate? So you told so many investigations, isn't it? So what are the investigations? You just repeat. So one is routine test. Apart from this, for coronary artery disease, what are the things you did?
For the intra,
No, investigation.
sir, sir, routine blood count, sir,
Yeah.
and
Apart
then
from that,
coagulation profile
mm.
and LFT because of the
So ECG
cholestasis.
and echo you have done, isn't it? Okay.
Yes, sir.
Okay. So, because it is asymptomatic, you no need to investigate further. If the patient has some other symptoms or chest pain or there is an ECG change, then you have to investigate further to find out what is the cause for that ST changes or the chest pain for this patient. Okay.
Yes,
So,
sir.
what is your plan of anesthesia for this patient?
Sir?
What is your plan of anesthesia for this patient for laparoscopic cholecystectomy? Whether you will go for
General anesthesia, sir.
okay, so it is
Plan.
only general anesthesia. Okay, so whether it is general anesthesia or you will like to add a epidural, so which we can use it for intraoperative as well as postoperative pain relief. What I suggest,
Because
you should, yeah, tell me.
because it is a laparoscopic surgery, if it was open, then I would have considered epidural.
No,
If there is a
it is not a lone anesthesia, the epidural. I would like
with along
with general anesthesia. I will always like to combine epidural for this patient, particularly coronary artery disease with laparoscopic surgery, general anesthesia with an epidural catheter. Okay, I'll give a local which can reduce the intraoperative period problems, reduce anesthesia. It will reduce intraoperative stress responses, and also it can be used for postoperative pain relief. So your plan of anesthesia better should be general anesthesia with an epidural anesthesia. Okay.
Oh, okay, sir.
So what is the pre-medication you will give for this patient?
So you should start with the benzodiazepines should be given, and
What
the
benzodiazepine?
usual pre-medications for any patient, which is the hello.
Yeah, tell me. What pre-medication you will give? What are the orders you have written? You will write the pre-medication orders, no? So you should tell what is the pre-medication. You want to give any antacid or H2 blockers or PPI or benzodiazepine. What benzodiazepine you will give? When do you give? Whether it is a pre-operative night, previous night, or in the morning of surgery?
In the morning of the surgery, sir.
Previous night?
Previous night, the patient can be started on NSAID. So the patient can have a decrease sympathetic
So,
symptoms.
better to give a diazepam previous night and the day of surgery, and you will continue the beta blocker, whatever beta blockers, if he is on the day of surgery, and the anti-hypertensive and proton pump inhibitors in the previous day, night, and in the morning of surgery. Okay, so we have to get an informed consent for this patient about the risk involved, ischemia, infarction, and chance of patient going in for coronary intervention during intraoperative period or postoperative period. Everything has to be explained and has to be consent has to be obtained. Okay. So coming to this thing, what is your primary anesthetic goal in a patient with ischemic heart disease?
The goal is to avoid fluctuations in the heart rate and BP, sir.
Good, good.
And avoid ketamine, because that can.
The goal is not drugs.
Okay.
Okay. So you should avoid anything which causes myocardial imbalance, oxygen supply and demand ratio. You will maintain a low heart rate. Maintain an adequate coronary perfusion pressure, normal arterial blood pressure, normal myocardial contractility, and of course you reduce the intraoperative blood loss. So all these things, mainly it prevents the supply demand ratio, imbalance in the supply demand ratio. That is the primary anesthetic goal. Okay.
Okay, sir.
So what is the main pathophysiological difference for a myocardial infarction occurring in a non-operated patient and an perioperative patient? You understand this? A patient is not posted for surgery and a patient posted for surgery. Both the patients are getting myocardial infarction. What is the main pathological difference between these two MI?
One of them can is because of one of them is because of decrease the myocardial imbalance, sir, oxygen demand
Which one?
imbalance.
Which one?
That is the intra-op.
That is a operative patient.
In operative patient.
Non-operative patient?
That is because of thrombosis.
Yeah. So non-operative patient develop MI due to the rupture of the atheromatous plaque. Okay.
Yes.
But the operative or perioperative period patient will develop MI due to the prolonged imbalance between the myocardial oxygen supply and demand due to coronary artery disease. Okay. So that is the main difference in the pathophysiological difference between the myocardial infarction in a non-operated patient and a perioperative patient. Okay.
Yes,
what are the monitors you will employ in this patient? Monitoring.
So there will be the ECG leads.
No, it should not be very
start with the ECG.
ECG lead is single lead ECG, 2 lead ECG, 3 lead, 5 lead ECG.
5 lead ECG.
So any patient with coronary artery disease, you should not tell ECG, you should let 5 lead ECG.
5 lead ECG.
Why you want to maintain 5 lead ECG?
Because the V5, the precordial lead, that is the most sensitive.
Yeah, V5 and lead 2, it completely covers the entire spectrum of the heart, and any ischemia or arrhythmia can be identified with lead 2 and lead 5. Okay, that is why we put up 5 lead ECG. Okay, 5 lead ECG, then saturation, ETCO2, temperature monitoring, urine output monitoring, and this patient, because it causes increase in intrathoracic and intra-abdominal pressure and coronary artery disease patient, it can require intra-arterial blood pressure monitoring and a central venous pressure monitoring. If because this patient, your patient has a good hemodynamics and no other features of ischemia or infarction, there is no need for pulmonary artery pressure, as sir was telling. If the same patient has any regional wall motion abnormality or a low ejection fraction, patient or any ischemic changes in ECG, you need to put a pulmonary artery catheter to monitor the wedge pressure and also guide the intraoperative fluid requirements.
Okay, sir.
Okay, so because the pulmonary artery pressure is the first one to give the alertness during any intraoperative ischemia.
Yes,
Any
sir.
sudden rise in the pulmonary artery pressure or pulmonary artery wedge pressure during intraoperative period is the first sign before other ECG changes or blood pressure changes can occur. Pulmonary artery pressure changes first in the intraoperative period.
Yes, sir.
Okay. So what is the induction you will do, or what are the drugs you will use for the induction?
Sir, etomidate can be used.
Yeah,
Sir, because it
etomidate
is
is
for,
most ideal. Okay.
cardio stable. So,
Yeah. And
we'll start
narcotics?
with the narcotics. Morphine should be used, and an opioid can be used. Fentanyl, IV fentanyl can be used,
Yeah.
sir.
So
And,
morphine can be used in the pre-medication as well as here, but you fentanyl, etomidate, and benzodiazepine will be the ideal combination for induction of these patients, and can be, and sevoflurane and vecuronium is the least cardiovascular effect, and this can be considered for the as a relaxant and inhalational agent.
yes,
Okay.
sir. Okay, sir.
So what do you do to prevent intubation response, hemodynamic response during intubation?
Repeat the question, sir. As in?
No, during laryngoscopy is the main stress response, isn't it? So what are the techniques?
Esomeprazole infusion can be started, sir.
Which infusion? It is not the infusion, it's a bolus dose. Okay.
Bolus dose.
Plainly, most of the centers uses lignocaine, 1.5 milligram, 90 seconds prior to laryngoscopy.
Okay, sir.
Okay. So during the intraoperative period, you are using 5-lead ECG. What are the ECG criteria? You say it is a diagnostic of a patient developing intraoperative ischemia. So any patient who has a ST segment changes upsloping of more than 1 mm or downsloping of more than 2 mm, or there is an ST elevation or a T-wave inversion. So these are the ECG criteria to diagnose intraoperative ischemia.
Okay, sir.
Okay. How do you manage intraoperative tachycardia? Sir was asking, if a patient suddenly develops tachycardia intraoperative, how will you manage? First, what you will do?
Identify the cause of
good.
Tachycardia, sir.
So what will be the most commonest cause of intraoperative tachycardia?
The patient is coming out of the muscle.
Light plane of anesthesia. So you have to deepen the plane of anesthesia. Okay. Then search for other causes. Other causes can be in this patient,
blood loss.
blood loss, hypercarbia. Okay, ischemia, and other causes you have to identify and treat. Okay.
Yes, sir.
How do you manage intraoperative hypotension or hypertension? That also depends upon what is the cause of hypotension or hypertension. If it is hypertension due to light plane of anesthesia, you have to deepen, and hypertension due to bleeding, you have to start giving the fluids or blood as required. Okay. So how do you manage a stable ischemia? That was the sir was asking these questions. This thing. How do you manage if a stable ischemia? How will you manage? How will you manage an unstable ischemia?
Intraoperatively, the pain relief should be given, sir.
Yeah, sir was telling, no?
Opioid should be given.
Nitrates.
Nitrates and unless there is if there is bradycardia, no.
No, stable ischemia, unstable. Stable. What do you mean by stable and unstable?
Sir, if it is stable angina,
No, what do you mean by stable, unstable? How to term patient? as a stable or unstable? Depends upon what?
The vitals.
Yeah, what vital? It is depends upon the blood pressure.
Heart,
Yeah, heart
and
rate.
heart rate and blood
Yeah.
pressure.
Okay. Yeah. So it
Okay,
depends
sir.
upon the hemodynamic changes. So,
Mm.
and it has to be treated accordingly. So, how do you extubate this patient? Sir already completed this question and told the answer also.
In deep plane of
Yeah, deep plane of
anesthesia.
anesthesia. And whatever the stress, to prevent stress response you give during intubation has to be given during extubation also to prevent the stressor response.
Okay, sir.
How do you manage pain post-operatively?
Post-operative pain, epidural catheter can be
Yeah, this patient,
inserted for
because we use epidural, this thing can continue pain relief during post-operative period. Or if not, it's a multimodal analgesia for the this thing, NSAIDs, narcotics, and so on, and local, whatever. Okay, so it is a multimodal anesthesia. So when usually perioperative MI occurs, intraoperative or postoperative, or when usually it occurs?
when
Usually perioperative MI occurs
first
1 to 4 days.
72 hours.
Yeah, 1 to 4 days after surgery. Okay,
Yeah.
when that is when the effect of anesthesia wears and the fluid shift, whatever the major surgeries, all the fluid shift occurs. So usually perioperative MI occurs first 1 to 4 days after surgery because of wearing of anesthesia and the majority of fluid shifts occurs. Okay, sir, anything you want to ask?
Vijay,
Yeah.
Actually, one thing is we can intubate with rocuronium bromide, very much
Yes, sir.
cardiac stable.
Yes, sir.
So we can induce with, as usual, midazolam, fentanyl, etomidate, and rocuronium
Yes,
with
sir.
Xylocat. Okay,
Yes,
that is
sir.
fine. And second thing is this tachycardia. Many centers and many anesthesiologists miss hypovolemia.
Yes, sir.
Because always the cardiac patient, they'll be very hesitant to give fluid. And many times this patient will be having hypovolemia.
Yes, sir.
So better to assess the volume status when there is tachycardia.
Yes,
These
sir.
are the two things which I would like to add. And third thing, I mean, many points I know that you will come later. So hey, I started in between. I don't know. So I'm sorry about that.
No problem, sir.
And post-operatively, first 72 hours, any mortality, an anesthetist is liable as per the norms today. Legally, we are bound. So
Yes.
first 72 hours, you have to be very careful about the fluid management, pain management, and monitoring for ischemia and continue all the cardiac medications. Okay, this is about post-op. Okay, Vijay, please continue. Yeah.
Yes, sir. So these are the main questions. Almost we have covered around 125 questions. So
Oh,
that is
fine.
what this thing. So whatever the case discussion will, the target is minimum 100 questions, usual questions.
Okay.
We'll cover for that. So I think we have covered this thing. Anything more want to be discussed or this thing?
No, almost we have covered all the points.
Yes, sir.
You
So
came
there
in a
is
methodical way.
yes, sir.
Methodical way. Yeah.
There is a question, epidural catheter at which level? So that depends upon the surgery. So because it is the laparoscopic cholecystectomy, not much of actually pain will be there actually. And in the thoracic level, we can put and cover up to T4. That should be fine for laparoscopic cholecystectomy.
Okay, sir.
And that also will use it in the post-operative period.
Okay, sir.
Yeah.
You say one point we have forgotten.
Yes, sir.
Intra-op and post-op, we should be very careful about temperature maintenance.
Yes, sir.
Which can cause a lot of deleterious effects on heart
Yes,
rate.
sir. Yes, sir.
Okay.
Yes, sir.
Okay.
Yeah, monitoring we have included the temperature this thing.
But we normally don't concentrate. In
Yeah.
post-op, normally they'll have some shivering,
Yes.
vigor, or some kind of struggle they have.
Yes,
And
sir.
always add antiemetic, always in these cases. because this nausea and vomiting can cause tachycardia.
Yes, sir. Yes.
This
Okay,
retching.
sir.
Okay, okay, Vijay. Okay, fine. Good, Vijay.
Yes, sir. I think we have come almost 1 hour and 40 minutes there in this
Yeah, correct.
session. And it is a very good discussion. And thank you, sir, for joining. And next week we'll be having anesthesia for a pediatric patient coming for cleft lip and palate surgery. Dr. Rajini Sundar from GKNM will be moderating with me, and our postgraduate will present the case. So next week, Tuesday, that is 31st of August, 7 o'clock, we'll have anesthesia for a cleft lip and palate correction. So next 2 weeks will be pediatrics. One is this thing is cleft lip and palate next week, and 7th will be tetralogy of palate patient coming for cerebral abscess. That is actually this talk is both for practical as well as theory. It will be useful. So both the cases, of course, cleft lip and palate, and of course, TOF patient, both are questions in the theory as well as in the practicals. Okay, and thank you for everyone who was joined. And I think next few weeks will be linear period because practical just got over and theory is on the way. Today is the first paper, and I think next 3 days will be theory papers for DNBs. And after that, I think again it will kickstart. Anyway, we'll continue this every week, and we'll go on. Okay, thank you, sir. Thank you, Dr.
Okay,
Rakhi.
sir. Thank you, sir.
Thanks, Vijay.
Thank you,
Thanks
sir.
for giving the opportunity, Pa. Bye, Pa.
Yeah,
Wish you
night.
all the
Thank
best
you,
to all
sir.
the postgraduates. Bye. Good night.
Thank you, sir.
Good night.
Bye, sir.